Okay, I think we're going to get started. We've got um, a lot of people online already, and I don't want to penalize you guys for being on time. Anyways, good afternoon, and welcome to the Spring Pharmacy Forum presented by the Canadian Foundation for Pharmacy. The topic for today's forum is decoding the insurance industry. For those of you who don't know me, my name is Linda Pertula, and I am the Executive Director for the Canadian Foundation for Pharmacy. The Canadian Foundation for Pharmacy began in 1945, 80 years ago. It's Canada's only registered national charity for pharmacy, and its mission in 6 words is to help advance the profession of pharmacy. We do that by raising funds and grants and awards that our board of directors bestows on deserving researchers, innovators, and leaders in the pharmacy. Through our innovation fund, for example, we've granted over $2 million for 37 research projects, many of which help prove the value of pharmacy services under the expanded scope of practice. And our Wellspring Leadership Award provides pharmacists with up to $10,000 yearly in financial aid to foster and develop leadership. CFP also advances the profession through educational content like today's Pharmacy Forum. We have our Pharmacy Management Textbook in Canada, which is an invaluable resource for pharmacy students and pharmacy owners. Just as the profession continues to evolve, so does the Foundation. We have finalized our new strategic plan that will allow us to better collaborate with other stakeholders to identify key gaps in research and the evidence still holding the profession back. Then we can better target our funding towards high quality research advocacy initiatives that will help fill these gaps and ensure pharmacy's advancement. We couldn't do this without donations from individuals and support of our corporate partners. If you're not already a donor, I'd ask each of you here today to consider adding CFP to your personal list of charities. It's an easy, effective way to give back to the profession. And on that note, I'd like to thank today's sponsors for our event. Our platinum sponsors are Loblaw Shoppers Drug Mart, GSK, Amgen. Our gold sponsors are Pfizer, AbbVie, and AstraZeneca. Before we get going, I just wanted to let you know that today's session is being recorded and will be available on our website after the presentation. And if you have any questions during the seminar, please put them in the Q&A section and we'll make sure that they're addressed. Okay, that's it for me. It's now my pleasure to introduce our speaker for today, Jeff May. Jeff is a subject matter expert, a healthcare executive, and a pharmacist and a founder of Northern Sky Healthcare Consulting. He brings more than 20 years of experience collaborating with Canada Health Benefits Insurance Sector. Jeff will provide an overview of the health benefits environment in Canada, its stakeholders, their strategies, the economic forces that drive the insurance industry and impact pharmacy. Welcome, Jeff.
Thank you, Linda, and it's great to be here with all of you today. I have been always and remain a great supporter of the foundation and to be contributing to the debates and discussion that we're having these days in pharmacy. To note that I'm actually here with you today because a pharmacist saved my life. Now, it's not what you think. It wasn't cardiac event or CPR or rescuing me with an EpiPen. And for those of you who know me, know that I've had a few of those in my life. I'd like to take you back when I was 15 years old, and I was a very severe person living with asthma. I was one of the first people to use salbutamol in Canada, which changed my life at the time. And I was on oral prednisone, and my mom would give me epinephrine shots out of an ampule. And it also led to many trips to the hospital. And inhaled steroids were just being introduced, beclomethasone being one of them. And the current knowledge of asthma as an inflammatory disease was really just in its infancy, frankly. And as a 50-year-old kid living in Winnipeg, living in Edmonton, I didn't hold back. My parents was a smoker, and it was the 70s. What can I say? It was a different time, but I was in rough shape, and I was using a salbutamol inhaler a week as I said. And my parents got our prescriptions at a now defunct department store called Woodward's. And we went there. They had a low fee, no judgment, but we didn't have a lot of money back then. And they had a low fee, but they also had two of the best pharmacists I have ever encountered in my life. And there was one day my parents got a call from one of the pharmacists to warn of my increasing salbutamol use and that we really needed to focus on getting better treatment. And so my parents schooled me, and we had some family discussions. Nothing really changed, and a few weeks went by, and after more salbutamol refills, a pharmacist by the name of Sheila Kelcher actually showed up at the front door of our house, and she wanted to have a discussion with my parents around her concerns about my treatment. And basically, the message that I remember was if something didn't change, I was at risk of not seeing my 16th birthday because of the cumulative effect of inflammation. I needed to get on different medications. So that actually gave a wake-up call to my family. We got a referral to a respiratory therapist, and a respiratory specialist, which I hadn't been seeing. Got on high-dose beclomethasone, a drug trial, and frankly, it changed my life. I could breathe again. And Sheila, she was my mentor, my advocate, and eventually became my pharmacy professor at the University of Alberta. And she really gave me the reason to be a pharmacist and imprinted me forever. So I like to share that story with you because I think it's relevant to the discussion today, and I'll come back to that later. So I became a pharmacist, as all of you know, and over my career, I've had many years of advocacy responsibilities. As Linda mentioned, I have worked with the health benefits industry. Along with Peter Zawadzki, was a founding member of FISC, the Pharmacy and Health Insurance Steering Coalition, a roundtable so that pharmacy and the health benefits industry could talk about caring for plan members and people, and developed a white paper with a global health reinsurance company on the impact of pharmacist interventions in disability management, and was part of negotiating teams and negotiating strategies for pharmacy provider agreements and fees in both the public and the private sector. So a couple quick disclosures. I don't have any uh, conflicts of interest to declare, but some of you, if you Google me, will see that I'm on the board of directors of Humanis RX, which does some work in the industry, but no conflict with community pharmacy. So our objectives for today, they're up on the screen. Really, my objective today is to help people in the pharmacy world understand what happens behind the claim. So on a day-to-day basis, as we submit claims electronically and interact with the health insurance industry, the drug benefits industry, there's a massive industry behind it, and understanding how that industry works helps to inform one decoding the industry and understanding why we're having this discussion around PPNs, and why do these initiatives and controls exist, and what are PPNs, and also to learn some of the drivers of competition and how pharmacists currently are influencing change in different ways. Now, I respect on the call today, there's likely people who are in the faction of passionately against PPNs, and there's some people that maybe work PPNs. There may be some people from the insurance and benefits industry themselves, and I know there's a lot of passion, a lot of emotion, a lot of activity going on. My role today is really to be fact-based, sharing information that's in the public domain, so not no company secrets or anything like that, and to really give you an unbiased view of why this industry exists and how pharmacy and the industry works together. So noted. I think the real question that I get a lot is, can pharmacy make a difference? And I think there's always an opportunity for innovation and partnership in this space. And in the past, there's been initiatives where pharmacy and the insurance industry, or players within the insurance industry, have made a difference and have developed strategies for pharmacy. And I think, back in the early 2000s, there was a fairly significant issue when I started working on a national level at Shoppers Drug Mart, and in Ontario in particular. There was a disagreement between some of the PBMs, ESI, Green Shield, and Assure at the time. And Green Shield had a $6.99 fee, and the others had UNC uh, back in the day of $9 and $10. Funny how things haven't changed that much given inflation. But the ESI gave the industry, ESI at the time gave the industry notice that they were invoking the level playing field. Uh, they're intending to invoke the level playing provision in their provider agreements, and um, that was the risk for pharmacy to cut their fees back to 6.99, which would have a significant economic impact. So I was on a team that was had a variety of discussions with Green Shield, some of Green Shield's customers, including the Canadian auto workers, and after some pretty tough negotiations and discussions about the role that pharmacy plays, and some action that individual pharmacists took in terms of informing Green Shield of their thoughts and ESI, for that matter. After a few, I would say, robust weeks of discussion, Green Shield moved to a 9.99 fee and a that kind of took away the level playing field agreement. And it was all based on good discussions around the value of pharmacy and the sustainability of pharmacy. So yeah, you can make a difference. So let's get into the exploration of the health benefits industry. And I really want to start by talking about why health benefits exist. And, well, as I said, on a day-to-day basis, we're pretty deep into the mechanics of managing drug plans. Health benefits exist for employers, union trusts, and others to provide um, employees an option to be healthy, to be productive, to be present. That means being able to perform their work tasks without interference of their health on their day-to-day, affecting their day-to-day life. And if I was a business owner, investing in health benefits absolutely makes sense because it's all about ensuring that the employee is supported, and benefits are a part of a total compensation package. The investment that's made is material to the individual employee, it's material to the business, but it really is an investment in health. And employees want to be supported in their health by their health benefits plan and be supported in navigating through their health benefits, having a good understanding of what the benefits cover and don't cover, and why controls exist, and really what's accessible to them that's relevant to their health needs for themselves and their families, and more on that to come. So the first player that we really need to talk about is the plan sponsor. That's the group, that's the language of the industry, and that's the employer. That's the group that purchases a benefit plan for their employees. And this can be, the human resource, typically led by the human resource department in medium to large size companies. There's also unions have health benefits negotiated into collective agreements. And there's groups like Ontario Teachers Insurance Plan, where collectively out of whether it's a union or a large group of employees, they create a trust that manages benefits on behalf of the members of that particular trust. So there's different types of plan sponsors, important to know, but really their objectives are all the same, and that is purchase and acquire and manage health benefits for their employees. And it really starts if you're starting out afresh, or if a company is, or a plan sponsor is renewing their benefits on an ongoing basis. It really starts with understanding their employee base and or their member needs. And that takes into account demographics, history of claims, history of health issues within the plan itself, and a variety of different factors around plan design, etc. There's a budget that gets set. Companies can afford a certain amount of investment, and typically in Canada, companies spend between $3,000 and $5,000 per employee per year on health benefits. And this cost is typically around 15% of annual payroll. But in some cases, companies may invest to a greater degree, in some cases up to 30% of their total payroll spend. So as you can see, it's a significant investment from a plan sponsor into their employee base. And the budget typically dictates called plan design, which is the structure of the plan. And yes, we're talking about drugs today, but it also takes into account dental, chiropractic, and other services. So all of that experience and needs of the employee base needs to be taken into consideration. And the plan design will also, budget related to the plan design will also dictate the type of cost sharing that comes into place, whether it's 100% paid by the company, whether there's deductibles, copays, and annual maximums in the plan. And we'll get into that in a minute. Plan administration is a large issue. And when we talk about plan administration, from a very simple perspective, it's enrolling new employees into a plan, employees that leave the organization, getting them off the plan, and answering questions that come from the employee base on an ongoing basis. Also tracking costs and analytics to make sure that the plan is achieving the objectives that are set out at the beginning of every benefit year. And that can be done by different types of administrative structures, which we'll get into in a minute. Risk is really the key issue here. And if you think of um, entering into a benefits year, you have an idea based on experience, actuarial science as to what would be expected as a cost in a specific population. But there's also risks of, an employee gets a gets a condition, or a family member gets a condition that requires a high cost drug that may be $100,000, $200,000 a year. Who wants to take that risk is a key decision. And that's where you get into plans that are built to be insured. Insured meaning the insurance company takes all the risk and the plan sponsor pays a premium for the insurance company to manage that risk. Or the risk can sit on the plan sponsor where they pay for all the claims in what's called an ASO, or administrative services only plan. The plan sponsor pays for all the claims and pays somebody to administer those claims, typically 2 to 5% of a total claim cost. And then there's hybrid plans where it may be ASO, but high cost drug exposure is insured in a different ways to protect the employer from that catastrophic, any catastrophic impacts as well, which come with a premium. So that's what happens at the plan sponsor level, all the things they need to take into account when they're building a benefit plan. Let's talk about the industry itself. So the health insurance sector is a massive part of the Canadian economy. It's big business. And I have some facts here from the Canadian Life and Health Insurance Facts Guide 2024 edition. 27 million Canadians have health benefits coverage provided by 64 companies that provide health insurance. And there's 121 companies that sell health insurance, and they collect over 55 billion in annual premiums and fees. And you can see on the chart on the right-hand side of the slide that 48.2 billion was paid out in 2023 for health benefits, drug and dental being the largest component of that. And you can see as you go around the circle, all of the components of health benefits that come into play and the costs of those. And industry reports state that historically, the value of this industry, or the payouts and health benefits, have grown between 3 to 5%. That rate of acceleration has changed with the advent of high cost specialty drugs. And generally, the consensus around the publicly available industry reports is that this industry will grow at about 7.5%. So, as I said, big investment, big dollars. And the insurance industry reports that of the 55 billion they claim, they collect in annual premiums and fees. 85%, sorry, gets paid out in claims, 9% in operating costs, 3% in taxes, and they take 3% in profit. Again, big business in Canada. So, sector economics. What's really interesting is in my early work with the industry, back in my Shoppers Drug Mart days, as we were talking to insurers and brokers about PCAPs and PPNs, we talked about how pharmacists can better manage employee health, plan member health, to reduce claims and costs. And in one of the meetings, I was stopped by a CEO of a benefits provider, PBM, and he said, "Jeff, one thing you need to understand about this industry is today's claim is tomorrow's premium." So the number of claims creates the experience for an employee group, and the growth of that, obviously, as per the previous slide, generates additional revenue. But there's this really interesting yin and yang in the industry, the push and pull. While insurance industry obviously wants to grow and manage more claims, there's a definite drive to reduce plan sponsor costs for all of the benefits that are in the health benefits portfolio, but more specifically, drugs as one of the largest expenses. So it's that yin and yang around, yes, we want to do more claims, we want to do more business, but the people that we're selling insurance to, the plan sponsor, the company, the union, the benefit trust, they're trying to reduce their cost exposure. So implementing strategies to manage costs while still having that push and pull around claims and premium and ASO fees creates a very interesting dynamic and very unique dynamic in the industry. Next is a little navigation through who the players are. So you're going to see a few logos over the next slides. I'm sure you recognize all of them. Uh, in the insurance world, the big three, Canada Life, Manulife, and Sun Life, they, according to industry reports, cover 60%, 60 to 70% of the industry, or around 19 million lives. They're very solid, traditional insurance companies in Canada, invest a lot into the Canadian economy and have their own unique strategies. Sort of the next level is as you look through the list of insurers in Canada, Green Shield, Desjardins, and the Blue Crosses, to name a few. They have to compete with the big players, so they tend to be more innovative on the product and service offerings. And there's a number of players that are also focused on either regional needs or industry needs. These companies, they sometimes sell directly to plan sponsors, or they sell through brokers or PBMs. Now, all of these companies have health and pharmacy disciplines. I'll talk more about that in a few slides. But they do have pharmacists on staff. They have pharmacy strategies. They build formularies. They have strategies to reduce costs for medications that in some cases include PPNs or types of PPNs and other cost management strategies. And pharmacists and pharmacy as a contributor to that. The next group are benefits brokers or administrators. And these are the groups that sell group benefits insurance products to and services to plan sponsors. Now, these groups, what they do is they work with a plan sponsor to understand the plan sponsor's needs based on what I mentioned previously. And they will go out to the insurance industry, or they will have insurance partners and product and service partners who will put together a package that best meets the needs of that plan sponsor. And in some cases, they'll put out competing bids to insurers to try and really get the best deal for the plan sponsor that meets their health and financial needs. Some of these groups do their own claims administration. Others will partner with TELUS, Express Scripts Canada, and some of the other TPAs and PBMs. Some of the larger players in this space, Benefits Trust, People Corporation, Benefits Alliance, and Manion, just to name a few. And as I said, they compete on their ability to bring a product that meets the needs of the plan sponsor. And underneath that, they have health promotion, wellness programs, programming, disability management. They provide advice on cost management and also provide analytics on how plans are performing on a year-over-year basis so that the plan sponsor can make sure that the plan evolves to the needs of the finances of the business and the needs of their employees. Now, every one of these companies does have a strategy around drugs and pharmacy that includes formularies, talking about pharmacy professional fees, PPNs of varying types, digital and online pharmacy offerings, and they also have strategies around high-cost drugs. And they compete on that basis as well. And these companies typically will make, for generating new business, they'll make a sales pitch to a plan sponsor, or to retain their business or renew the business, they'll have a sales pitch. And in every one of those pitch decks, I've seen some of them, not all of them, obviously. There's a discussion on drugs and pharmacy. And I would say that in this industry, pharmacy and drug benefit management are table stakes. Going into, for one of these groups to go into a plan sponsor without a discussion on drug cost management and drug management within the employee base, they're not going to get a lot of business and they're not going to grow. The next group of stakeholders, what I call consultants and influencers. These are organizations that advise larger companies. So the first group, consultants like Mercer, Eckler, Willis, just to name a few, they work with typically medium to large companies to build human resources, total compensation, benefits, insurance, and retirement strategies. It's very uh, comprehensive and takes into account the idea of a total compensation strategy. Now, they will help companies that are looking to transition and change plans, or if there's been mergers and acquisitions of companies, they will advise as to how to manage integrating all those various benefit strategies. I was on a team at Shoppers many, many years ago, um, working with, I believe it was Mercer at the time, as to how to properly amalgamate some of the various benefit plans that existed in the Shoppers Drug Mart world. It was a very interesting experience because of the breadth of knowledge and analytics that they brought to the company so that the company can make a great, great decision. And they do have opinions on cost management, obviously, with pharmacy and formulary strategies. Our partners in the pharmaceutical industry, both brand and now generic, particularly with the biosimilar world, they have what are called market access teams, and their goal is to ensure that their products get covered under formularies, ideally with as few restrictions as possible. Now, to promote new drugs and new therapies that they have brought to market, they will typically invest with health benefits providers to help them deliver, whether it's health programming or disease awareness programming, so that employees can be supported in their journey with new therapies. And there's some very innovative work that's going on and continues to go on in the industry. A lot of the current focus in that space is around high cost drugs, biosims, mental health, ADHD, weight management, and diabetes. And there's a group of innovators, I would say, Cubic being one, developed, I think, probably 15, 20 years ago by two amazingly and amazing and brilliant pharmacists who created an analytic strategy to help plan sponsors, sorry, look at their claims in a different way and influence claim design that's more disease specific and getting at some of the employee behavioral issues and driving plan design towards that. Um, uh, and been very successful. They're also involved in some very innovative prior authorization activity. Reformulary Group is another one that was started by Helen Stevenson, who was previously with the Ontario Drug Benefit Plan and reformed that plan, as those in the pharmacy sector will recall. Her company has built and sells a very highly managed formulary that reinvests into the formulary to drive a lower cost in the industry. I think it's also important to give a shout out to Benefits Canada for pharmacists, pharmacy owners who are really looking to understand what's happening in the benefits industry, to understand the lingo and the various drivers. Get a subscription to Benefits Canada. I look at my Benefits Canada feed pretty much every day just to learn what's happening in the industry. There's some great thought leaders in that space. And there's also some very interesting conferences that do focus on drug plan management and health benefits. The next group is, I think, a group that pharmacists have varying opinions of. And these are third-party administrators or pharmacy benefit managers. And you know the groups that are on the page, obviously. Now, in the insurance space, let's just step back from the day-to-day relationship that pharmacy has in terms of submitting and getting claims payment. These groups exist to process claims, and they operate network switches that manages the traffic between pharmacies, dental offices, other health benefits providers for the purposes of payment. And they generate revenue, obviously, on managing that network traffic, paid for by the insurance company and ultimately embedded into the cost for plan sponsors, whether it's fees or premiums. These groups, because they manage data and claims data, provide drug utilization reviews, pharmacy cost information, and other analytics back to the industry to be able to understand what trends exist in the industry that help to influence plan design and policies around managing drug costs and also managing employee health. Now, from a pharmacy perspective, um, there's a very important relationship that exists between a pharmacy business and the TPA or PBM, and that's the pharmacy provider agreement. And the pharmacy provider agreement exists to very clearly define the terms and relationships between the payers and the provider. And typically they're quite one-sided. They exist to protect and manage the costs and risks of the insurance product. And within that, obviously, there's terms around reimbursement and all the details around claim submission, which I'm not going to get into. But they also have the provisions for audit to prevent what's called FWA in some circles, fraud, wastage, and abuse, so that the plan is being managed effectively. That's why these folks exist. And I know there's lots of opinions about how these groups are operating in the industry. Um, it won't speak to specific companies, but I think one thing that's really important and a message that I've always shared with pharmacy operators and owners is you need to understand your rights within these agreements. You need to understand the terms of the agreements so that you're not operating outside the agreement because operating in the gray or in the dark can cost you, as a pharmacy business owner, a fair bit of money. So let's get into and shift gears a little bit around employees and their benefit plans. And we know that prescription drugs are the largest expenditure, but they also generate the largest number of claims. And this is from the 2023 Benefits Canada Healthcare Survey. And it shows that you can see heavy users of prescription drugs, 26% of the population, 20% are medium users, really compared to the other health benefits, clearly prescription drugs are the most important and they drive the greatest cost. And there's lots of emotion in plans and amongst employees around some of the other plan elements. I managed a company that had about 300 employees, and massage therapy was my third largest cost. I thought, wow, I'd love to be able to take some of that and reinvest. And anytime I brought up the idea of taking massage therapy away, I was told I would have a revolt on my hands. So looking at the comprehensive aspect of these plans is super important. Now, all of you will be familiar with these with the formulary controls that we deal with in pharmacy on an administrative basis. But to give you the perspective of the industry, prior authorization and its kind of partner step therapy exists to ensure that prescribing is following a good clinical pathway and that the plan member is not just going to the most expensive drug first. So the controls that exist around prior authorization and the related administration around that exists as a means to achieve appropriate drug use and appropriate cost management. A formulary design, there's typically three types of formularies: open, which is like the Mandarin buffet. If the doctor prescribes anything, it'll get covered by the plan. The opposite of that is a closed formulary, which doesn't really exist to a great degree in Canada, is more of an American phenomenon where there's limited options. It could be generic only, and on the brand drug list, it's a very tight list of products. Typically, those, in an American context, those who are willing to pay the highest rebates into the formulary will get preferential treatment on the plan. And as I said, that's a U.S. phenomenon. Most formularies in Canada are what would be described as managed, that include prior authorization, step therapy, and and generic management, etc. And underneath all of this is our product listing agreements. And product listing agreements are where the pharmaceutical manufacturer pays a certain amount of money to get listed in the formulary. And it's not widely known. It's actually not reported at all. It's very confidential as to what these PLAs are, but they do exist, and it does create I won't say significant, but amount of revenue back into the benefits plan that helps to either reduce the risk exposure for the plan sponsor or the cost of benefits themselves. choices on plan design. This is from Express Scripts Canada 2024 Drug Trend Report. These are the tools that drive member behavior. And what's interesting around what Express Scripts provided is the adoption rate. So generic substitution, as we know, is very high in Canada. It has accelerated actually over the last number of years as a means of cost savings. Co-payments exist in 71% of plans, and that also says that the converse is that 30% of plans don't have any co-payment and provide um, coverage. Annual maximums where benefits are limited to X thousands of dollars per year, and after that, either the plan member is on their own or dips into some of the provincial social safety net programs. Dispensing fee caps exist in about 38% of plans, and step therapy exists in 44. Now, I think it's important to note that for plan sponsors, particularly given the economic environment that we're in, we do see shifts in companies that are robust and healthy from a profitability perspective, profitability earnings perspective. They'll have the ability to invest in benefit structures and assume more of the cost for the employees. As on the opposite side of that, companies that are struggling financially, where there's low margins or pressures such as tariffs that we're starting to see in Canada, pressure on controlling expenses in the P&L, which includes benefit plans, is going to be a discussion. It absolutely will be a discussion, and there's going to be lots of pressure as we go through this turbulent economic time to ensure that benefit plan design is meeting the financial capacity of the plan sponsor, which might mean more controls or more cost sharing with employees. Now, plan sponsor concerns, again, from the Benefits Canada Healthcare Survey, you can see as you look down this list, there's really an issue of concern on increasing costs and sustainability. And that means the ability to sustain the benefit program at the level the company is investing in and the level of cost sharing that exists. So that again, that sustainability piece and the amount of cost that passed on to members, you can see comes out quite aggressively in this slide. It'll be interesting to see what happens in this year's or next year's survey to see if these concerns go up. I'd also like to draw your attention to number 8, the growing number of appeals or complaints, and that's how the plan sponsor has to manage their employee base and concerns about levels of coverage, the complexity of coverage. Why do I have to go through hoops with doctors and pharmacies to get this coverage? That is a source of work effort on behalf of the plan member or the plan administrator. And I think that's been growing because plan design has grown in complexity. I think that's important to note for the pharmacists on the or on the presentation today. Now, sponsor concerns as it relates to some of the therapeutic areas, obviously biologics and biosimilars, high cost drugs or specialty drugs have changed drug therapy for sure and are a benefit in managing health and health concerns with Canadians. And the growth of biosimilars driving more high cost drugs and creating concern around drug plan sustainability has been somewhat muted by the introduction of biosimilars. And a lot of plans are also deferring the costs of high cost specialty drugs to the public plan and having the public plan take on the risk exposure there. That's an evolving discussion in Canada. And new therapies, particularly high costs or high cost therapies for rare diseases, is another evolving discussion in the industry. And directing a lot of that is directed towards the discussion on national pharmacare, the national drug approach, but also provincial drug programs absorbing costs for some of these rare diseases. Diabetes and obesity, weight management with the introduction of GLP-1s, they've exploded to the top of drug utilization lists in private plans. Express Scripts reported in their recent drug trend report that 45% of patients that were using semaglutide didn't have another drug for diabetes as part of their therapy, which would likely indicate or infer that they're using the product for weight loss. And so the growing demand for these services or for these products historically in plan design, weight management, obesity was treated more of as a lifestyle condition and not a chronic disease. So plans are trying to figure out how to manage the demand, manage supporting weight loss in their employee benefits drug program. And I think the aspect of affordability, what that means to premiums or ASO costs, will be has been and will continue to be an important discussion in the next 12 months. And finally, a note on managing chronic diseases. There's like semaglutide, the growth of ADHD therapies shooting up to the top 10 of or drug utilization review lists as well as a concern. So there's a lot of push around mental health programming and support for diabetes, supports for cardiac conditions, and also comorbid chronic disease is an important discussion around managing costs and managing the employee health of employees. And one final note on specialty drugs. Um, 31% of drug spend, total drug spend is on specialty high cost drugs, but it's 1.8% of claimants, with the average cost being almost $30,000. A reference point there is the average cost per claimant for the rest of the population of claimants is between $400 and $600. That varies by PBM reports. So plans have implemented a mechanism called stop loss. That's that insurance product or premium product where the exposure on those drugs is insured. And the industry actually created CDIP, a pooling corporation, so the insurers can reinsure their risk so as not to adversely affect their continued ability to pay claims. Now, in this space, let's talk about insurers, TPAs, and brokers and how they're bringing pharmacy services into their business and why. We know Express Scripts Canada has a pharmacy, TELUS Health has a virtual pharmacy through an acquisition in Aurora. Um, the approach here is really to provide an integrated service, to, to be able to promote a robust service that includes a suite of offerings, typically employee assistance programs, mental health strategies, um, more intuitive consumer apps that help them to understand their drug benefits plan and their plan design a little bit more in detail, integrating cognitive behavioral therapy into their offerings. Virtual care is also becoming part of the offering in this space. And I'll also note that Green Shield is also playing in this space with some very innovative apps as well, as is Sun Life with their Luminal Health investment and Manulife with their partnership with Dialogue. It's all about the industry creating, again, to sell to plan sponsors, to manage that pull between claims processing and premiums and supporting the health of and being shown as and being a partner in supporting the health and well-being of employees through an integrated offering. Now let's explore PPNs a little bit. So I've been involved in discussions around PPNs and VCAPs going back to the late 90s. And back in the 90s, it really was a fee game. And there were pharmacy providers in Western Canada where I was practicing at the time and across Canada where large corporate entities went to zero fee or discounted their professional fee as a means to compete in the pharmacy space. And what that did at the time was it exposed the professional fee to the plan sponsor world. And that was never under discussion. So now suddenly it became a discussion about what pharmacies have different professional fees, and that led to the benefits industry and plan sponsors finding pharmacies that would be able to save money for their plan sponsors and plan members. That led to in 2000s letting in store discounts, copay discounts, wellness programs, integrating loyalty programs when they existed or for front shop. And now we see that PPNs are really, while they do vary in structure and size, you can see that specialty drugs are now part of PPN arrangements and chronic disease support is integrated. So This is what exists in the market today. And there's pharmacy providers that play this game. There's pharmacy providers that don't play this game. But from an insurance industry perspective, a plan sponsor health benefit industry, these types of interventions are seen as a way to be able to manage the cost curve for plan sponsors. And I know there's many opinions about that in the room today. So PPNs in Canada today, there's open plans where there's reduced dispensing fees, fee caps, retail discounts, retail loyalty offers, and clinical programming. And when they're open, it's voluntary for the employee. The plan sponsor promotes these services as being available, and they leave it to the employee as a consumer to decide where they get their prescriptions filled. But there's obviously encouragement to help on behalf of the plan sponsor to help the plan be sustainable and save money. There's obviously encouragement there to be a participate in cost management. On the other side, closed pharmacy networks are basically you must use the network pharmacy or must use the pharmacy that's owned by the plan sponsor. And if you go outside of that, either there's significant penalties or no coverage. Not many of those in Canada, much more of an American phenomenon for sure. And then in the middle, there's what I would describe as semi-open for PPNs that where there's out of network penalties. So, your plan, your copay might be 20% if you're in network. And if you go out of network, it might be 20, 30, 40, 50%. There's a variety of different designs out there. Or there's copay offsets, et cetera. So that's what I call semi-open. And again, those are typically voluntary and typically where the plan sponsor implements them as a cost saving mechanism, recognizing that not all of the employees will participate in the PPN strategy, but they're looking for more of them to do that as a cost-saving measure. Now, the impacts of pharmacy, for those of you who are frontline practitioners, you know that the plan design uh, has an administrative burden. It takes time to go through step therapy. It takes time to go through prior auth. It takes time to manage claims reconciliation, et cetera. And through some of the forums that have been created over the years, there's been discussion as to how to manage that down. Now, there has been a trend where costs for managing drug plans are being pushed into the pharmacy space, certainly a topic of debate. And there's also concerns that are coming out of pharmacies around some of the closed PPNs about breaking continuity of care, which is an important discussion that the industry needs to have. And of course, there's pharmacy sectors that are concerned about the viability of pharmacies as costs get pushed down to them. And we only need to look to the United States as a cautionary tale, where the pharmacy benefit manager in the American context is really in the middle, and that's where the profitability is, and they determine who wins and loses from a pharma perspective, but also from a pharmacy perspective. And some of the stories around pharmacy deserts and closures of pharmacies and some of the large corporations who are in the pharmacy benefit business getting out of it, it's a real mess down there. And I haven't shared a lot of personal opinions, but I'll be biased on this one and say I think this is where we have to put up a wall. We don't want to see this environment in Canada. I don't think it's good for the industry, and I don't think it's good for pharmacy, and I know it's not good for Canadian patients. So let's talk about what's happening in the industry today. Tons of debate, a lot of this focused on Ontario. And I think pharmacy and the industry has really awakened around the need to engage the health benefits industry and have discussions and debates around some of the important things that are happening and some of the American influences that are happening. Pharmacy associations, provincial associations or national association, CPHA has certainly been engaged in this. There is a discussion going on about provider agreements, a discussion going on through the Competition Bureau that's looking at whether or not some of the behavior of the industry is inappropriate given Canadian competition law. Won't comment much more than that on that piece. That discussion will evolve over the upcoming months. We know that there's a very intense debate that's happening in Ontario and a consultation that the Ministry of Finance is conducting with the various sectors in the industry around the structure of PPNs, how that influences patient behavior and patient choice in their healthcare. And the Ontario College of Pharmacists is also actively involved in that discussion. I think as this consultation evolves, we will see statements coming out, whether it's as some groups are looking for an outright ban, whether it's an any willing provider or any willing able provider, as has been discussed, how that's going to evolve. I think we'll get some clarity in the next few months. And there's media presence. There's lots of discussion in the media and lots of attention in the media about the importance that and the thoughts that pharmacy has about this evolving environment and defending the importance of the relationship that pharmacists have with their patients and preserving patient choice and the media observations around what's happening. So, I know there's lots of opinions out there. I think it's good that the debate is coming and that pharmacy is playing a significant role. I even think down to the practicing pharmacist level, there's influence. If you look at this last slide around what's happening or employees who are looking for information based on their use of benefits, 64% said they want more information. And if you look at what's in that slide, recommendations for services covered by health benefits plans, how to be healthy, how to manage their condition. Well, guess what? That's what the pharmacist does. And I think the pharmacist and pharmacies have an opportunity to be the advocate. And in as I've given this presentation to various groups, I think it's really important for the pharmacy to be able to help patients be their advocate. If they have questions or concerns about their drug coverage, about their benefits plan, pharmacy playing a role to be that plan navigator and helping the employee, the plan member, ask good questions of their union, their benefit trust, or advocate to say, if this aspect of plan design doesn't really meet my health needs or it doesn't respect what I need as an individual. And increasingly, there's a group of, from a pharmacy perspective, from a patient perspective, really the key piece is here. I want choice. I still want choice of my benefits provider or my pharmacy provider as my benefits plan and maybe dictating me otherwise. So I think the most important message from a pharmacist perspective is be close to your patients, live up to your care promise, provide the best service that you can uh, to your patients, be the best professional with your patients, help them to be advocates for great care under their benefits plan and work with their plan sponsor. But at the end of the day, it's the most important thing we can do to contribute to the best health outcomes and ultimately cost management within the industry. And I take you back to my personal story. Um, if 15-year-old Jeff May existed today with the health concerns that I had at the time, and I got a prescription for a high-cost biologic drug to treat my asthma, now COPD, I would be an advocate. I would want my pharmacist. I would want Sheila Kelcher to be my advocate. I would want her to be the center of my care, and I wouldn't want any distractions around that. And I know a lot of pharmacists feel that way as well. But the bottom line is you have to practice to the top to the top of your license, to the top of your professional capability to be the best pharmacist you can for your patient. And that creates the best advocacy that we can have for this industry because you never know. One of your patients could be the VP of a large corporation in Canada who's about to make a decision around their drug benefits and those drug benefits interact with your pharmacy. So I think it's a great discussion that we're having these today. I know there's lots of opinions on either side. My objective today was just to share with you some of the real basics around why the insurance industry does what it does, some of the economics around the industry, the importance of this industry for Canada, and how potentially we can interact with the industry going forward. So I'd like to say thank you to Linda and the Canadian Foundation for Pharmacy for the opportunity to present to you today. And I think, Linda, we do have an opportunity to take questions if there's any in the chat.
That was we do have one. It says, thank you for this timely presentation, Jeff. Much appreciated.
Thank you very much.
That was one of the, and I have to agree with that. It was a fantastic presentation. Sort of took a topic that has been very cloudy and almost mystical and clarified it for, I'm sure, myself and many of the others out there. So I'm just going to see if there's, I don't think I have any other questions. See, it was such a good job. Nobody has any questions for you.
Well, I
I
think
did.
everybody knows how to find me. I haven't necessarily been as active as I once was in the conference and pharmacy space, but I think everybody knows how to track me down if they do have questions or concerns or wants to debate or take issue with some of the stuff I said today.
I have a question for you.
Sure.
Like I was at a presentation hearing about what's happening in the US. What are the chances of that actually coming to Canada? I mean, I know if we do all the right things, it won't, but if you had a crystal ball, what would you
You
say?
know, I think over the year there's been a waxing and waning of opinions around whether or not you know, TBM, HMO strategies are going to exist in Canada. And that's actually kind of gone with the economic environment and the economy, whether we're in recession or whether we're in a growth in our GDP and a healthy economy. I think going into this very uncertain phase, as I said earlier, the need for plan sponsors to manage costs and manage the risk exposure is going to create more conversations about more aggressive controls and benefits plans. But one thing that's been true in the conversations that has happened in my experience over the last 20, 30 years is in Canada, the one thing we value the most is that the Canadians value and want choice of their healthcare provider. That has always been the case. And um, that as a value in Canadian healthcare, I don't know if that's going to change. I think that is something that's embedded in how we think in Canada, and I will influence plan sponsors in the insurance industry to be able to, to, to respect that as a Canadian value and what's important to the people in the country.
Perfect. Thank you. Michael in the chat wants to ask you a question. You there, Michael?
Can you hear me now?
Yep.
Thank you,
Michael,
Jeff. Excellent presentation. Very informative as usual. Um, this is a little bit of an odd question, but as we're doing our advocacy works on PPN, something does keep coming up, and I'm wondering if this is a new phenomenon or something that we're just coming up more and more now. The role of wholesalers in PPNs. More and more, we're seeing insurance companies saying, "Well, we will cover the drug, but you have to buy it from a specific wholesaler." And I'm assuming there's probably some kind of PLA or rebate going around between a wholesaler and the insurance company structured in some kind of legal manner to make it above board. Is this a new phenomenon, or is this something that that that's more of a new experience that we're seeing based on what you've seen in yours?
I can only answer that, Michael, and thank you for the question. I can only base that on my observation of the industry and not being in active practice, working in pharmacy as I once did. Um, I believe that's a new phenomenon. I don't recall that being something that's in the environment. Um, you know, again, drives towards managing costs, cost growth as the average value of a prescription is going up, is causing the industry to look at ways that they can create more predictability around their risk. So I can't really comment on that as a strategy specifically, Michael, because it's obviously not uh, something in the public domain around those arrangements. But I think, if that's something that impacts the day-to-day practice or potentially the profitability of pharmacy, it's something that's worth discussing in the industry.
Oops. He
Okay, thank you
muted
so much.
himself. Okay.
Yeah, thank you so much. Really appreciate that answer. Great presentation.
Thank you.
So I have two here. One of them is a comment from Matt in Alberta. He said, "Shout out to Sheila, such a great role model and a mentor as well for me as my young pharmacy career at the Faculty of Pharmacy at U of A." So you have the
Thanks,
fan
Matt.
club.
Absolutely.
So then I have an anonymous one. Do you have any indication of uptake by plan members of pharmacies owned by PBMs?
No, I don't. That information isn't in public domain, and I don't have that knowledge myself.
There we go. I think that pretty well covers it. Oh, there's no. Oh, sorry. Um, Rita has a question for you. There's been a lot of talk about this sector being regulated. Thoughts?
Boy, that might require another 20 minutes or so as a discussion. Thanks, Rita. Um, I won't share my personal opinions on that. I think that the consultation that is underway with the Ministry of Finance has highlighted and advocacy has highlighted whether or not there should be some regulation in the industry, and that brings into play some of the American phenomenons. Should PBMs own pharmacies? Should what are the contractual terms that exist between the various players in the industry, and are those respectful of what's happening, the competitive environment in Canada? And is there any anti-competitive activity that's going on there? Again, that will all be flushed out in the debates that are happening over the few years. I think the most important um, piece of the consultation in Ontario, and if you haven't looked at it, I think it's publicly available on the Ministry of Finance's website, is a discussion around any willing and able provider, whether that should exist. We know in Quebec, should have noted earlier that PPNs really don't exist in Quebec because of the unique regulatory environment that exists there. Should that exist in Ontario? That's a base of the of the discussion, and I think there's an opinion, and it hasn't really been in the public domain, but I would expect that the insurance industry, the health benefits industry, plan sponsors, um, as you've seen in my presentation today, there is a very strong, there's a lot of inertia around it, managing the risk of increasing drug costs. I'm certain that they will have opinions that they don't want regulation in the space, and they obviously have a very important investment in the Canadian economy and a very important investment in supporting drug benefits. So I know I'm being a little, I'm hopping on the fence here. I think as the debate happens, it's really important. And what we've seen is the various sectors speaking about what's right in the industry. And I think through the debate, and whether that's pharmacy and the insurance industry, getting to a discussion around partnership and what really should exist in the environment for the best come for Canadians out of their health benefits insurance. Um, Important discussion. Personally, I don't want to see the American environment in Canada. As I said earlier, I don't think it's right for Canadians. I don't think it's right for the industry. And who knows? If National Pharmacare takes over, this whole discussion goes away, and we're talking with the federal government. So that's a pretty cloudy crystal ball right now.
All right, I think we've gotten all the questions. Do you still have control? Can you do the next
Oh, yes, of
slide?
course.
Yeah.
That's important.
Anyways, thanks once again to Jeff for a fantastic presentation. I hope everybody got as much out of it as I did. I'd like to thank once again our platinum sponsors, Shoppers Drug Mart, Loblaws, GSK, and our gold, and Amgen, and our gold sponsors, Pfizer, AbbVie. Is that it?
That's it.
That's it. Perfect. Anyways, as I just had somebody ask a question, this webinar will be available probably as of tomorrow morning on our website. So if you've had to leave early, or you have a friend that was not able to attend, please let them know. And we will have another webinar again in the fall. And if you guys are in the Niagara area next week, we are hosting, along with Open and AFPC, the first Pharmacy Practice Research Symposium. There's a mouthful. All day next Friday from 9 till 5. So I hope if you're in the area, check out on our website. You can register through there as well. All right. Have a wonderful day, everybody. And thank you. Oh, I guess got 2 more Q&As. Oh, they're all thank yous. Hey, have a wonderful day, everybody, and we'll chat soon. Take care.
Thank you.
Bye.